trying to be positive. This is the first intro that I'm doing where I'm going to be on YouTube. So I've added tricks. So if you're just listening to this from the audio podcast perspective, you're missing out. I just did a back handspring and then I caught my mic in my teeth and then I just did this intro. No, I'm lying to you. But wouldn't that be cool? You should 100% subscribe to our YouTube channel because then maybe if I one day learn how to do that, you'll catch it. As for now, introducing easily the most honest and very warm and lovely guest that I have had, the lovely Dr. Victory. He was fantastic. There were points of this interview where my mouth was agape because I couldn't believe what he was saying. Not in that it was things that I didn't already know to be true and believe myself, but rather because it was a doctor confirming what so many of my patients and myself will say to one another all the time. It was extremely validating. I hope that you enjoy this episode as much as I enjoyed recording it. On to the number one, Dr. Victory. You just got out of the OR. That's like a casual...
I did, yes.
Casual day. Just, he might be late because he's been operating on someone. I was like, I might be late because I got coffee.
I wish I was late sometimes only because I bought coffee. No, we operate Wednesdays, typically. That's like a planned OR day. And then during that day, I'll have cases like removing cysts or fibroids. Today was a mix of several different cases. So
right. So is it mostly just gynecological surgery independent of fertility, or is it always connected to fertility?
Yeah, once upon a time, it used to be just gynecologic surgery in general. And as the years have gone by and our fertility practice has really kind of taken over, less and less do I do conventional kind of gynecologic surgery. Now it's more fertility focused. So removing endometriosis, removing fibroids, reshaping the uterus, taking out polyps, dilating the cervix, treating endometriosis, which is a big one. And then, of course, there are some patients who have come to the end of their fertility journey and have trouble with their uterus, either because they're bleeding too much or it's too painful and they want definitive surgery. So they're asking for hysterectomies. And I do everything minimally invasive. So it's all done laparoscopically or hysteroscopically. And for some patients, that's a big advantage because they don't have to stay in hospital or get the big cuts.
Yeah, but I was originally introduced to your work when I was hosting sort of a call-in for my followers to tell me their fertility stories. And one woman wrote to me and said that she wanted to tell me anonymously about her fertility journey, and you were her physician, but she moved from Toronto to Windsor. Moved her life so that you could be her doctor. And I couldn't get over it.
Yeah, I know exactly who you're speaking about.
She was bored of me constantly asking if I was like, are you serious? You left your whole life just to go and be treated in Windsor? And she said, yes. With that, I would do it again. I have to meet this doctor. I have to meet the man. Because when I think of Windsor, I think of...
I am very blessed.
It's... Why Windsor? My experience with the Windsor is related to track and field, where I would go as a track athlete with U of T. I would be slaughtered by the Windsor team, and then I would return home with my tail between my legs. So that was my previous experience with Windsor until you. So perhaps you could enlighten me as to why Windsor?
Well, it's a bit of a long story. It's got a very funny basis to it, but essentially when my wife and I decided that I would do my fellowship, and of course, it was a family discussion between her and myself. We already had 3 kids. And my oldest son needed kind of advanced schooling because he could read and write when he was 2.5. So we went and looked, and I was doing my fellowship in infertility in Detroit, and we went and looked for a school there, and it was, I mean, the cost was insane. So we decided to live in Windsor, and then I would commute back and forth for the duration of my fellowship, which was 3 years. And then once we did that, I started working here, kind of moonlighting and assisting, and I realized Windsor really didn't have the kind of fertility clinic I wanted to establish. There's Dr. Pattinson here. He's retiring shortly, in a month, in fact, but he wasn't quite doing what I wanted to do. And so I saw it as an opportunity to bring something great to a city that supported me while I was, trying to get through my fellowship. And so that's how we ended up staying in Windsor. And then, having been here for quite some time now, A, it's home, and B, it's been very, very good to us. And we were able to really draw a lot of attention to what we do and get government funding for the program, which has helped, hundreds of people now. So we're really pleased with what Windsor has provided us. And I don't have any misgivings about it. I probably could have been bigger and better in another community, but it's not about being bigger and better. It's about helping people out. So
I think that you're doing pretty well. I have all of these patients from Toronto who are driving to Windsor just to see you.
Yeah.
And now, actually, if something's not necessarily going, I don't want to say my way, one of my patients' way, I'll say, I've got just the man. Hold on. You've got to go see Dr. Victory. And they're like, you think he'll see me? I said, he listens to everybody. He will see you. You're like the Wizard of Oz.
Oh, gosh. No, I'm not a wizard. I believe in being honest with people, and I study a lot. I'm definitely no wizard. But, I think I am very critical of the fertility world because I think it's extremely financially driven. And the care component of what we are supposed to do as physicians is becoming less and less important as more and more fertility clinics are kind of either being purchased by venture capital or private equity, or they're just motivated to get bigger and make more money and grow. And because of that, it's become less and less about patients and more about business. So, I get it. Like, I'm running a business too, but at the same time, my priority is always going to be my patients. And I think it's really hard to, kind of provide the same level of care when you're owned by private equity or venture capital, or your goal is financial, that it is when your goal is just, I want to go to sleep at night knowing I did a good job for people. So I think because of that kind of approach that we have has really resonated with people. And yeah, people are coming from all over Canada, all over America, the whole world. Like, it's been extraordinary, the outpouring that we've had of support and interest in what we do here.
I think that's because you want to help people become pregnant as opposed to start treatment. It's very challenging being an alternative practitioner and having the views that I do, because I don't want to ever come off as, a conspiracy theorist and not appreciating what science has to offer, because I do tremendously respect science and Western medicine. But the component that you just spoke about in terms of venture capitalists and investment and ensuring that investors are making back their investment by way of ensuring that a certain number of treatments are done and that a certain number of patients are doing IVF rounds is something I don't think is getting enough attention, and something that I want to bring a lot of attention to. Because if patients knew, when I've brought up to patients, are you aware that this fertility center just raised, for example, $20 million? that means that their valuation is upwards of like $80 to $100 million. What is being offered to the investors to make that money back? And how can you ensure that that's going to happen unless you're guaranteeing that you're going to sell X amount of treatments? So now it becomes a lot less about what a person needs and instead becomes a lot more about what the clinic needs. And so the fact that you just led with that, I'm unbelievably grateful.
Yeah, well, I'm probably as critical as you are. I think it's gone in the wrong direction, and it is very financially driven. It's worse in the U.S. It's becoming very similar in Canada. I've been to the UK. It's the same thing over there. They're all corporately owned by venture capital funds. They're these big conglomerates, and there's no question. The care is substandard in the UK. It's terrible. In the US, a lot of patients they walk through the door and they actually, this is terrifying for me as a physician. They have this thing called a conversion rate. A conversion rate is a metric used to determine how many patients that walk through the door the doctor can convince to do IVF. It shouldn't be about convincing people of anything. You should be diagnosing them, educating them on what's wrong, explaining to them what's wrong, explaining what all of their options are, and then helping them to make a good decision for them. But the decision has to come from the patients, not from us. Like, obviously there are circumstances where people need IVF. If you have horrible sperm, you're probably going to need IVF. If you have blocked fallopian tubes, you definitely need IVF. But aside from some very rare circumstances, generally speaking, there are options. And what's missing in a lot of what we're doing in modern fertility is the ability to provide people that education component and the options component and the understanding that's necessary to make a good, sort of constructive decision for themselves. We're just kind of pushing people into things. And in my opinion, that's wrong on every level. It's ethically wrong, it's morally wrong, and it's scientifically wrong too. So I don't think it's a good model, and I think it'll come crashing down around us at some point when people realize this has just become big business and there's no care involved in it.
I think it also gives IVF a very negative spin because, as you were saying, originally it was intended when there was no way for egg and sperm to meet. And now it's being used for every possible reason that someone, from unexplained to, this is faster than if you were to go home and try naturally, which one of my favorite things to tell patients is if you need IVF, then IVF is what you should do. But if you're doing IVF because you think that it's going to be faster, you are going to be so disappointed because there is so much waiting. And it is rarely the faster option if it's not what you actually need. I think it's very interesting to have your perspective on that. I know that you do a lot of treatments outside of just IVF. You were one of the first doctors that I had heard of from my patients that was doing PRP. And now it seems to have sort of filtered this way as like a new treatment. And I was like, Dr. Victory's been doing this for several years now. You guys are behind. So in your experience, do you think PRP is valuable? And do you think ovarian PRP and PRP for the uterine lining, would you say one is more successful than the other? And do you use it on a regular basis? And who do you use it for?
Well, there are three kind of categories of PRP use. So there's PRP to thicken the uterine lining for women that have a thin uterine lining. And that's one of the kind of banes of our existence. It's hard to get the lining to thicken sometimes. So the data for using PRP to thicken the lining is actually pretty convincing. There's randomized controlled trial data on that now that suggests you can get kind of 1 to 2 millimeters of thickness, which is often enough to make it work. So from the perspective of, hey, my lining's thin, I want to use PRP. Yeah, great. It's a good idea. It works very well. It's not cheap, but it's also not extraordinarily expensive. And so I'm a supporter of using it for that. From the second standpoint, I've had unexplained implantation failures and I want to get my uterus to be more receptive. Can PRP help me with that? And the answer to that is, again, yes, there is pretty convincing data now that demonstrates that you can get almost a 50% increase in that group of patients who have genetically normal embryos. Everything else is okay. They're still not getting pregnant. You give them PRP 2 days before the embryo transfer, and then you do your frozen embryo transfer, and you do get this huge increase in success. So in that regard, it can also be beneficial. The big one, which a lot of people are talking about, is ovarian PRP to rejuvenate the ovaries. So it's very, very question mark right now. I mean, we're not sure if it works. There are 3 reasonably well done studies and then a bunch of junk studies. So out of the 3 reasonable ones, one involved just over 500 women, about 530 women. And in that study, they were able to demonstrate that 15% of these women that previously had tried and failed ended up having a live birth. Now, 15% is a terrible, number as far as a high success rate is concerned, but 15% when you were previously getting 0 for people that are desperate is obviously better than 0. The other 2 studies are randomized controlled trials. One did demonstrate an increase in the number of eggs that people got, but did not look at live birth. The other one showed that there was absolutely no benefit to doing it. So the data is really equivocal right now. Like you've got 2 yeses kind of and a no. And so when I'm discussing it with patients, what I frequently do is go through the math, because I literally take a call at least every day from someone who's 43, 44 and says, I've got diminished ovarian reserve. I want to do PRP. And I say, no problem. Like, I'm happy to help you, but we need to chat about the math because you need a lot of eggs to succeed at 43, 44. And you need a lot of good quality eggs. And PRP might make you make 1 or 2 extra eggs. But if I need you to make me 20 and you're going to go from making 1 or 2 to 3 or 4, I'm still going to need to do IVF on you, 6 times, 8 times. Is that reasonable? Not in my books. I mean, I think that's inhumane and you still can't provide people with a guarantee. So I have that chat with them. Now, in some cases, patients kind of it clicks and they understand and they say, yeah, that doesn't sound like what I want to do at all. And in other cases, patients say, I will do anything to try and have my own baby. And at that point, I'll say, well, as long as you understand that I cannot promise you results and you understand that I've presented all the data to you, like I said, people need to be educated and then make decisions that are right for them. I don't force people into anything. I make sure they understand what to expect. And I'm very kind of brutally honest about that. And then if they understand it, like if they still want to go ahead, that's their choice. I'm here to support their decision, not to force them down one path or another.
I suppose for cases where it truly is like diminished ovarian reserve, there aren't that many other options. So 15%, like you were saying, is better than nothing. So,
and I mean, we combine it with naturopathy. We combine it with, acupuncture. We talk a lot to patients about nutritional support and getting their health balanced so that they're approaching this from a holistic perspective. The idea that you just, ram people through what I call the IVF grinder, where you over and over again do the same thing. I mean, that meets Freud's definition of insanity, right? Doing the same thing over and over again and expecting a different outcome. So we don't do that here. We rather take a very holistic approach. And I do try and be on the cutting edge of science. So if there's evidence that something looks promising and the evidence is convincing, like the PRP, the first couple of studies did look like it might be beneficial, I'm willing to try something like that as long as I can kind of tell the patients what to expect. There's new data coming out that I learned about just last weekend from Chicago at a conference there, talking about the role of oxygen delivery to the ovaries and how that impacts egg quality. And maybe we should actually be retrieving eggs from older women in an immature state and then maturing them in the lab, because they'll do better in the lab than they will in the ovary. So, they presented a lot of science on it, and it actually does make some physiologic sense. So that's an area where, there are opportunities to intervene and take actually a very holistic naturopathic kind of approach with good, healthy oxygen delivery, reduce antioxidants, make sure that you're, controlling the oxidative damage, and then go forward from there. So I believe in that kind of integrated, holistic approach so that you're addressing all of the patient rather than how many cycles of IVF can we do for this to work.
I mean, obviously, I'm going to be supportive of the lifestyle component of fertility. But I am always shocked when I've had patients who have had fertility physicians that suggest that, diet, supplements, acupuncture, none of it really matters. I'm like, there's a lot of data that suggests otherwise. And even if you use just common sense, if you take a healthy person and then you take somebody who is ill, who is going to do better with surgery? Like, what would you, if you were just a resident back in residency and you were watching you were part of general surgery, who is going to have a better outcome?
Yeah.
Somebody who is healthy or somebody who is unhealthy, using like blood pressure, body weight, physical capacity? Who are you betting on? And obviously they're going to say, well, the healthy person. I'm like, well, why does that change when you're now trying to use sperm and egg cells to make a human? I don't understand where that goes out the window, but that's me.
I'll tell you, it's not just you. So you're on the right side of that debate. The problem is that car companies don't make money if the cars don't break down. Cell phone companies don't make money if your cell phone doesn't break down. And so the motivation to get people to succeed in IVF is limited by the fact that, again, there's a desire to make money. So there's no question, if you take a more holistic approach, if you get your patient healthier, if you get better sperm and you get better eggs, there is absolutely no question, it's incontrovertible that you're going to need to do it less. And to the clinic, that's a financial disadvantage. So, anyone claiming, any physician, naturopath, it doesn't matter, whoever it is, that claims that once you go down the IVF route, your nutrition and your vitamin intake and, your wellness don't matter is simply not reading. I mean, that's clearly evident in the data that's out there. And we know that makes a huge difference to outcomes. But the question is, are they motivated to improve the outcomes? And the answer is no, because when you improve the outcomes, you actually are making it less financially beneficial to the doctor in the clinic. So if the clinic is, again, like we said, owned by venture capital, they're happy keeping a good success rate, but they don't want a great success rate because that means they're not making as much and they're just looking to sell to the next guy. So that's not a good model for taking care of patients.
In terms of what you were talking about with what you were learning in Chicago about retrieving immature eggs in a more mature patient, what size of the follicles, and would you have the same stim protocol and then just retrieve earlier?
That's what's being recommended, is that you stimulate the patients, but retrieve the eggs when they're, depending on how mature the patient is, you retrieve the eggs earlier than normal. So normally we're starting to look at triggering patients to retrieve their eggs when they have somewhere around an 18 to 20 millimeter follicle. The gentleman that was presenting the data has published on this, showing that between 40 and I think 45, he recommends triggering at 16, and between 45 and over, you should do it when they're between 12 to 14 millimeters. Now, the logic behind this is essentially, in layman's terms, these eggs are being suffocated because they're not getting enough oxygen. And so if we get them out before they're damaged by the lack of oxygen, and we oxygenate them properly in the lab, that they'll actually do better. Now, the data on this is one study that he himself has published, and it's not crystal clear that the outcomes were better because he hasn't gone so far as to show live birth. So we don't know for sure, but the supporting data that he based the science of this idea on was actually pretty convincing. And so it does make sense, even so far as that I was actually looking at naturopathic clinics around us, because if you think that oxygen delivery is the key, maybe hyperbaric oxygen is one of the things that we should be looking at. And sure enough, when I looked it up, there is some data out there that suggests that patients that do hyperbaric oxygen therapy when they're going into fertility treatments actually have better outcomes. So this is something we're now looking at as well, to assess how much of an impact can this sort of treatment have on how the patients do.
That's very interesting. Something that I'm particularly interested in right now is dispelling the myths around physical activity and fertility treatments, and the need for different types of physical activity per patient, but that the idea of not continuing exercise routines when doing stims is actually misguided. And if you're being careful, and obviously not, like a HIIT workout, for example, is not going to be tremendously beneficial right before retrieval. But up until,
Right.
3 or 4 days before you're going to be triggered, it's actually, the science indicates that patients have better outcomes than those who are not remaining physically active. So with that in mind, and the idea of the importance of oxygen and oxygen delivery throughout the body, it's just an interesting correlation. And maybe that's why exercise is benefiting these patients, in a side, better insulin sensitivity as well, and overall circulation. In terms of other alternative treatments that you are doing that I wish more physicians were doing, it's supposedly very controversial, but I don't know why it's so controversial. A lot of physicians are even saying that they don't believe in reproductive immunology, which is insane because there is a university that is heading it up in the States. But this boogeyman that is reproductive immunology, I'm wondering if you could dispel a few myths for me. Specifically, I'm interested in your take on the theories around NK cells being elevated and how that impacts fertility, cytokines being elevated, how that impacts fertility, and the most controversial of all, the LAD and how it impacts fertility.
So reproductive immunology gets a bad rap for sure. And the reason that it gets a bad rap is that the science behind what to do is not nearly as strong as the science behind what's wrong. I mean, there are 2 entire journals purely dedicated to reproductive immunology. So we know that there is science backing a lot of these claims that your immune system is important. And even the smartest guy I've ever met in all of infertility is a gentleman by the name of Richard Scott. He's probably forgotten more than all the rest of us combined could ever learn. But, he will say openly, in fact, he just had a debate in Chicago with the person that directs that American Reproductive Immunology program. He said, look, we know that the immune system is important. No one's questioning that. But we don't know what to do with it or how to standardize the testing. And that's why it's got a bad rap. It's because people don't know what to do when they find something wrong, and they don't feel that the studies that have come out to date have demonstrated either rigorous enough scientific methodology or significant enough outcomes to justify the invasiveness or the expense of the treatment. So are NK cells important? Of course they are. No one's going to argue that. Do we have very clear data that reducing the NK cells will yield a different outcome? No. We have data, but is it crystal clear that, for example, if you take intralipids and steroids, you're going to do better than the person that doesn't? We don't actually have that data. So that's where the problem is. And so those of us who practice it know that it works because we use it and we see the difference between pre-use and post-use. But it's hard to convince people because you can't standardize the testing across the board. They can't even decide where to test the NK cells. Do you get it from your blood? Do you have to do a biopsy from the endometrium? And then even if you can get the testing standardized, the treatment isn't necessarily standardized. And some of it's very complex. You get people that have a lot of NK cells, but they're not particularly aggressive. You get people that don't have a lot, but they are aggressive. You get people that have both. You get people that have high cytokines, like you mentioned. And so each of these plays, a different role and requires different treatments. As far as LADs are concerned, the way I always explain it to people is your immune system is constantly on watch for foreign invaders. And those foreign invaders are typically bacteria or viruses. And it's waiting for something foreign to enter so it can kill it, because it doesn't belong there. Well, when an embryo lands inside a woman, it's half her, but it's also half not her. And sometimes the immune system will kind of look at the embryo and go, well, that doesn't look like it belongs here, let's kill it. So the whole idea behind the LAD is to sensitize the woman's body to her partner's antigens, the proteins, so that when her immune system actually encounters the embryo, it goes, oh yeah, we've seen that before. It didn't cause a problem. We're okay with it. And it does work remarkably well. I mean, that I can tell you clinically, we see huge results from that.
I don't have the same amount of experience, but I will say anecdotally, over the last 10 years, it's hard to ignore the number of patients that I've had where they've had unexplained infertility and then they've gone through every other potential option only to end up getting LIT treatment and then becoming pregnant thereafter, either by doing a transfer or conceiving spontaneously. And it's become so much a part of my practice that it's hard for me not to want to let everybody know about this as an option. And it's also equally confusing to me why it's not being used more. Because in instances where I've had, other physicians speak on why they wouldn't want to use it in more cases, it's sort of rattled off that it's potentially harmful and that there's a lot of risk. But from what I can understand, there's a lot more risk in other fertility treatments than there would be in the LIT.
Yeah, there's a hell of a lot more risk from sticking a 2-foot needle in people than under ultrasound guidance than there is from giving someone LIT therapy. Yeah, I mean, LIT's really pretty harmless. Is it appropriate for every patient? No, of course not. But if you've been tested and you've demonstrated negative or marginal antipaternal antibodies, and you have a history of failure, I mean, I wouldn't do it for someone that just out of the blue had a problem. But if they had a history of recurrent implantation failures or recurrent pregnancy losses, yeah, I mean, it does actually make a significant, substantial difference. And arguments of safety, again, are probably not the main reason why it's not done. The main reason why it's not done is keeping up with the information that comes out on fertility is a 24/7 job. I mean, I read 6 journals every day just to stay on top of it. I don't sleep much. I work nonstop. My kids are all out of the house. So, my goal is always to be at the forefront of knowledge. But let's be realistic. Most fertility doctors went into fertility medicine because it's more of like a 8 to 4 job, and you don't have any emergencies, and it's easy, and the money is good. And so people don't feel necessarily compelled to go and become the very best at this and learn constantly. They're happy again with that like slightly better than average rate where people are happy that they're getting good care, but there's just enough room for them to come back a few more times. And so it takes a lot of commitment to know the fertility stuff, know the reproductive immunology stuff, know the surgical stuff. There are very few of us around that do that. Very, very, very few of us around that do that.
Yeah, but I think it's also the key to want to remain on the forefront of knowledge that helps one remain open-minded as well. I feel like a lot of the issues with fertility and the lack of care is also stemming from just the desire to remain status quo. But instead of saying, you know what, I don't actually know, but this physician does, or that's not my area of expertise. I have a colleague who it is their area of expertise. Why don't I refer you to that clinic? Instead, it's just this concept of, well, that's nonsense, or that there's no science. And there's a lot of science, or it's not nonsense. And I just don't understand where this closed-minded attitude is coming from and why it seems to be so prevalent with fertility, where it's not necessarily in other disciplines. Like, for instance, my son had a kidney issue early in his life, and I spent a great deal of time in the hospital. And I was very combative with his main pediatrician and nephrologist. And one day, the one pediatrician, bless his soul, pulled me aside and said, I don't really understand where this is coming from. Like, you seem like a very nice person, but you're unsure, and you don't seem to trust me, and you're questioning everything that I'm recommending. And I said to him, I have to be totally honest with you. I work mostly in fertility, and I really trusted physicians up until about 8 years ago, when I started noticing my patients would be given treatment protocols that didn't make any sense. And they would be given, recommendations that were not for their best interest. And as soon as I told him, I work in fertility, he said, oh, I totally get it. Okay, don't worry. This isn't like this. I have your son's best interest. It was a real turning point in terms of that trust piece. Like, if I was to go to any other discipline, like when I go to my dermatologist or when I go to my family doctor and they recommend that I do X, Y, and Z, I comply without question because I just know that they have my best interest. But I would really struggle now knowing what I know with fertility and going into a fertility doctor's office and having the same sort of trusting relationship. So I really do appreciate what you're saying on here. It's so valuable. I feel like this is going to be problematic for you, actually, because now people are going to listen to this podcast and you're going to be flooded with requests. People are going to be WhatsApping.
We're here to help people.
Trying to spread the word. It's bad. Wazing all the way to Windsor. I promised a patient that I would ask you this question specifically. In terms of microbiome and testing the microbiome, traditionally it's done with a biopsy. From what I understand, the standard test, the Emma Alice, but there's now another option offered by Fertility, where you're collecting menstrual blood and sending
That's
it
right.
away to be analyzed. What is your opinion on the pros and cons of each test, and what would you recommend for the general public?
So the pros of doing Fertility are that there's no pain, which is the con of doing iGenomics, because the biopsy is not fun. It's what I usually refer to as medieval torture for a woman. So there's no biopsy necessary. It's self-collected, so you don't need a doctor. You don't have to visit anyone or anything like that. And it can pretty much be done anywhere. You just have to be able to freeze the sample once you're done. And they do give you more information than the Emma Alice tests do. They have extra information on viruses and yeast and so on. And quantitatively, I like the way they report it better. And in addition to that, they do immunological testing too, and we frequently mix the two. So I will have my patients do the microbiome, but I'll also have them test their immunological status to see if they do need immunological treatments. So you can't do that through iGenomics with Emma Alice. To be honest, my main problem, I have nothing against iGenomics. The people that work there are great people. Actually, we will likely be using them for our genetics testing with pre-implantation genetic testing, because they have a great program for that. My problem in general is just that they are the folks that came out with the ERA, the endometrial receptivity array, which has been proven to not work, but they're still doing it. And for their corporate integrity, I wish they'd just admit that it doesn't work and pull it off the market. But it's kind of hard to tell people like this company is still marketing something that they know doesn't work, but you should go do this other test. So, it's hard for me to sell that. Like, I don't know how to phrase that even to convince people. So to me, it doesn't matter which one people choose. Fertility, I think, is a little bit more expensive, about $150 more expensive. And it does take a little while, but I'm very comfortable with them. So, we 99.999% of the time are doing it with Fertility, but I'm also getting a lot more information from it. So our patients tend to go in that direction. And we just did a study of the first 49 patients that we had done fertility testing on. These are all people that failed previously an embryo transfer or more than one embryo transfer. And from the 49 that we did fertility testing on and then addressed either microbiome or immunological issues or both, 45 of them got pregnant, 91%. So, the results are phenomenal. I can't get 91% even when people don't have those problems. So there is no question that this is working very, very, very well for us. And so, I must admit, while I am trying very much to be mentally avant-garde and accept new things, I also kind of believe in if it ain't broke, don't fix it. So in this case, when we've already got something really good with a team of people I know well and feel very comfortable with, I'm kind of guiding my patients more in that direction.
Yeah, that's fair. I've been astounded by the amount of information that Fertility provides people. I have run into the issue that it seems to be very hard if you don't have a fertility doctor that is in line with using Fertility to get your blood drawn for some of the testing. So I'm trying to provide more resources for that. I know there's a lot of nurse practitioners who are offering collection services for blood, which is very helpful, but I'm hoping it'll become more of an easier process for people the more it becomes popularized within Canada and North America. I was speaking with one of their reps and suggesting that they get more test centers, like set them up in Canada. And she said that something will be along those lines in the future, but didn't necessarily give me any more information as to what that would look like. But
I just had dinner with them in London, England, about 3-4 weeks ago, and they're wonderful people. We really like them. And I suggested that to them as well. I think they started off as a small company, and I think their growth has been so rapid, and probably in some part because I talk about them nonstop on our social media programs. So their growth has been so rapid, I think they weren't even prepared for it. So right now they're just trying to keep up with demand where they are. The idea of, expanding sites has not really sunken in for them yet. And I don't think that'll happen soon, although they do see the need for it. We have 4 locations in Ontario now. So some patients are coming to us, and there is more uptake. So I know one physician in particular at a very busy clinic in Toronto has reached out to me. I connected her with Fertility, so she's now using them. She actually just texted me today to tell me that the patient she used my protocol on is still pregnant and doing well. So we are seeing an uptick. So I think it will come around, and I think it will grow as more patients demand it, because obviously not everybody can come to me, and I think I was probably the first and only person doing it in Canada. But as the demand grows from people who see what we're doing in other centers, the other centers are going to feel compelled to do it. And it does work. There's no question it works. So I'm glad that they're doing it because it's improving patient care.
Something that I am starting to really push against is this idea of freezing one's eggs for fertility preservation and having that be, the be all and end all for insurance. It's my, very uneducated opinion that it's better, if you really truly want insurance, to use donor sperm and freeze embryos. So have a 50-50 split. If you're, I understand it's hard for like college students, for instance, to get in their heads like, my parents have just paid for me to have my eggs frozen, which if I'm looking back at my college experience, the time I would least want my eggs to be frozen would have been while I was at Queen's and U of T binge drinking. But that aside, wouldn't it be a better idea to give patients at least the understanding of what happens from like a fertility math standpoint, and that an egg doesn't equal a baby? So that if you freeze, for instance, like I just had a woman, she's 25, her company paid for egg freezing and they froze 7 eggs. And she's like, well, I've got my 7 kids, so I'm feeling really good about this. It's like, you are doomed.
Oh boy.
7 is not enough. We don't even know if they're going to fertilize. She was horrified by my idea of donor sperm. Right. But maybe you could shed your more educated light on this subject and give us your opinion on what one should do from an insurance standpoint, from both a college to 40-year-old standpoint.
Yeah. So I'm not a huge proponent of egg freezing unless donors are doing it to have egg banks. And even then, it's not as good as fresh. There's a lot of misinformation about egg freezing out there. There was a very recent publication, extremely recent, I think it came out last week, where this group published on the outcomes of using frozen eggs, of freezing your eggs and then going back and using them. And there was another gentleman that read the article and then wrote in and said, you guys forgot the key statistic. And the key statistic is there is a 2.7% chance per egg you're going to have a baby. Right. So the egg freezing market is being driven, again, by financial demand for women that are planning to delay their fertility and companies that want employees that are not hampered by a pregnant belly, and realize that if they pay $10,000 or whatever it costs, $6,000, $8,000, $10,000 for women to go freeze their eggs, they're going to get way more out of that employee in 9 months of working, plus the year that they're off, than they would if the patient got pregnant, and left for that period of time. And so it's very financially driven. And so the data that's out there is skewed, not to mention egg freezing is a joke for a fertility center and very profitable. So, we don't I don't promote egg freezing like a lot of other centers do, because if you look at the data, your chance of success with fresh eggs at 35 is basically going to be equivalent to your chance of success if you freeze eggs at any point up to the time that you're, 35. And once you're beyond 35, the number of eggs that you need to freeze to achieve even just one live birth is a lot. So up until 35, the estimate is you need 12 to 15 eggs to achieve one live birth. Beyond 35, it starts dramatically increasing to the point where when you're over 40, there's one paper that said you need over 60 frozen eggs. Who can get that when they're over 40? It's impossible. So we got to do a better job of educating women on egg freezing. Is it a viable option? Yes. Should it be used in certain circumstances? Absolutely. Is it good for everybody? No. I mean, it's not a universal insurance plan, and you're absolutely right. And I talk to my patients about that. I mean, you and I probably get along on every single thing you've mentioned today. The reality is that when I talk to patients about egg freezing, I tell them all, one of your options is to do a cycle or 2 cycles. And in one cycle, if you make enough, we'll use some for freezing and some for making embryos with donor sperm. Or do it twice, freeze some eggs so that if you meet Mr. Right and it doesn't happen until you're 38, 39, 40, you still have these nice young eggs to use. But at the same time, do another cycle and freeze some embryos just in case Mr. Right never shows up. At least we've got embryos for you, and those have a much better chance. So you're right. It is a discussion that everybody should receive, and they're not. I had a lady about a year ago contact me and say, "Oh, I froze my eggs." And I said, "What?" And she said, "Yeah, I froze 7 eggs, just like you said." And I said, "How old were you?" And she said, "I was 42. And I don't even know what to say. Like, I don't want to disparage my colleagues, because you don't want to be rude to anybody, and you don't want to undermine the people that work side by side with you. But at the same time, like, that is incredibly, incredibly misguided, uninformed, probably bordering on unethical treatment, because going into that, there's no way in hell that's going to work. And sure, you can tell the patient, well, it's your only chance. And if that lets you sleep at night, okay, but that certainly wouldn't be enough to let me sleep at night. I mean, I need to be clear that my patients understand that, at 42, freezing 7 eggs will likely yield you a 1 or 2% chance of having a baby. Now, if that's worth it for the 42-year-old and they say, great, okay, that's fine. But, is it clinically worth it? No, of course not. I mean, they're spending thousands of dollars, and then we'll have to come back and spend thousands more to turn them into embryos. And when it doesn't work, they're going to be devastated because they didn't get the full picture at the beginning. So we as physicians have an enormous moral, ethical obligation to deliver accurate and comprehensive and understandable information to patients. And we do a bad job at that often, way too often for me to feel comfortable about it. We have to do a better job. And that's why I'm super honest with my patients. I made whole videos on YouTube on calculating how many times you'll need to do IVF so that people understand what it's going to take. And we're actually preparing one for egg freezing as well, because of exactly what you said. There's a lot of misinformation out there, and people just don't get the fact that it's not what they think it is. It's not I got 7 eggs, I'm going to have 7 babies. 7 eggs, you may have no babies.
Yep, I'm so happy that you've basically agreed to everything that I've been telling people because now I'm going to sound so much more legitimate. I I can't even tell you. But a population that I'm getting more and more referrals because I had success with a few patients is the patients who froze their eggs prior to chemotherapy, where it was done in a very rushed capacity. And then they've tried to use the eggs after they've now entered remission, and they have not had success. And so they're coming to see me kind of at their 11th hour, hoping that, by some miracle, they will become pregnant with the eggs that they have post chemo. And what I've found is that I've been relatively successful. It is strange. Like, I've had really good success with patients who have previously undergone chemo, but weren't able to use the eggs that they had when they were initially ill. I can't explain why that's the case. I mean, you can say epigenetics are really important and that lifestyle has a lot more credibility than it's been given. I also have a theory that eggs are better protected than we think, and that a lot of medicine is based on, the male perspective. And if you did chemo on men and you damaged where the sperm are being produced, you're going to run into more problems, whereas eggs are already there. They don't need to be produced. It's just a matter of retrieving them and the process by which they mature. Anyway, I'm sure you can speak to that with much more eloquence, but the point of it is that it's very strange that the frozen eggs that were frozen pre-chemo are not viable. And in a lot of cases, because it's done in such an emergent capacity, they retrieve very few. So then they don't have a ton of options. And you're hoping in that case too, that your partner's sperm is going to be up to the job of fertilizing at that point, which if they hadn't been working towards it, they're not going to necessarily be ready either. So anyway, I really appreciate this whole conversation. Sure. I'm going to let you go because you probably need to go home and sleep and replenish yourself so that you can continue saving us all. Thank you so much for this conversation. I appreciate your honesty and your candor, and I hope that we can do this again because I'm positive that this is going to be an amazing response from our audience. Thank you so much for listening this week. Every time that you listen, you share, you rate, you review, it helps boost our show, which not only gives me the motivation to carry forth, but also helps attract new guests with new information. So thank you so much. Please don't forget, again, rate, review, subscribe to our YouTube channel, and we'll talk to you soon on the next episode.